Greetings everyone and welcome to the 124th session of the online Optom Learning Series or OOLS. And for today's session with us, we have Dr. Uday Kumar Addepalli. Dr. Uday graduated from the Bosch & Lomb School of Optometry in India, and then he attained his doctoral degree from the University of New South Wales, Australia. He is a clinician, a researcher, and a public health optometrist, and has a focus which is directed towards empowerment in rural communities and getting high quality comprehensive eye care services in that communities. He has held several different academic positions, not only in India, but also overseas, which includes Dubai and Africa. During his career at LV Prasad Eye Institute, he played a major role in establishing new vision centers in various parts of South India, in the rural communities especially, and has been actively involving himself in training these vision technicians. And the training involves to make sure that the vision technicians deliver high quality and sustainable eye care to the community. In his previous role, where he was a senior optometry consultant at the Light for the World, and he developed a proof of concept on establishing the first optometry internship hub for optometry graduates of the Makerere University in Uganda. He is a registered optometrist of the Australia and New Zealand area, and now as an optometrist with more than a decade of experience, he continues working for many national as well as international communities for supporting the elimination of avoidable blindness. So with that all experience, Dr. Uday is going to talk to us about the role of optometrists in glaucoma detection. It's a generalized perspective, what he's going to share his experience, his a number of years of experience on how can optometrists be important in detecting glaucoma. So welcome Dr. Uday onto our platform. Thank you so much for taking up this session and giving us your time.
Thank you so much, Fakhruddin, and thanks for those kind words.
Let me just leave the screen time to you now. Thank you so much.
Okay. So hello all, and welcome to the session. So as it was already mentioned that today I'm here to discuss the role of optometrists in glaucoma detection, which is a generalized perspective. Before that, let me wish you all good afternoon, good evening, and maybe good morning if my friends from Africa are also joined. So I'm Dr. Uday. As introduction has been, I just wanted to skip my introduction because Fakhruddin had already mentioned more than what I know about myself. So I'll start into the topic. So the outline of my session is that we'll be discussing, we'll be touching apart on definition and burden of the disease glaucoma, risk factors associated with that, the skills required, and the challenges faced during your role as an optometrist in glaucoma detection and referral system, and your scope as an optometrist. So your scope, in the sense, we'll cover the different aspects of it. And starting with the definition of glaucoma. I'm sure this part might have been covered many times by now by various lecturers, various speakers on this platform, but still bear with me for a while. So glaucoma is a group of eye diseases characterized by progressive optic neuropathy associated with correlating visual field loss. Actual definition doesn't have that word correlating visual field loss. It only says that visual field loss. But I prefer saying it correlating because there is always a correlation between the structural and the functional damage in glaucoma. So the global prevalence of glaucoma is about 3.54%, where primary open angle glaucoma alone contributes for 4.2%, which is almost 6% or more than primary angle closure glaucoma, which is at 1.09%. So primary open angle glaucoma is highest among Africans, and primary angle closure glaucoma is highest in Asians. So worldwide, an estimated 112 million are expected to be living with glaucoma by the end of 2040, disproportionately affecting people in Africa and Asia. So this is the estimated projection. Now moving on to the risk factors. Various risk factors associated with glaucoma are as follows: age, genetics, ethnicity, predominantly Africa and Asia, which I've already discussed, and high refractive errors, especially high myopia in open angle glaucomas and high hyperopia in angle closure disease. Intraocular pressure, which is the only modifiable risk factor, central corneal thickness, large optic discs, and other factors such as blood flow dynamics, and also other factors like genetics and others. So diagnosis of glaucoma at a primary level. So when I say primary level, I don't essentially mean vision technician level or ophthalmic assistant level. So this includes as an optometrist as well. So at a primary level, irrespective of the setting you are in, it requires a basic information on visual acuity, intraocular pressure, family history, and clinical signs, such as those seen in pupil, anterior chamber depth, disc hemorrhage or trans hemorrhages, optic nerve head appearance, retinal nerve fiber layer defects or changes, and visual fields or confrontation. So in a primary setting, it wouldn't be, I wouldn't consider visual fields as a mandatory or an important factor, because it can be it is usually, it's not so easy to be finding a visual field equipment in a primary eye care setup. So, and also keeping in mind the cost of the equipment itself, and the severity so visual fields can be looked at a higher level where an ophthalmologist is available to do the visual fields or to get the visual fields and use the visual fields only for grading the severity of the disease. So in my opinion, I don't need visual fields to diagnose or to suspect a patient to be having with glaucoma, but it is used to grade the severity of glaucoma. So visual fields is not not an option common to every setting. So when I say it's not common, either due to availability of the equipment or availability of the reliable result as well. Though glaucoma definition includes visual field loss, remember that you don't need to have a reliable visual field report to diagnose or suspect, as I have already explained. So when you see a definite morphological changes on disc or retinal nerve fiber layer or a high intraocular pressure correlating with a disc hemorrhage, then obviously you can be sure that this patient has glaucoma, whether you have a visual field report or not. So visual fields is undoubtedly an important factor in staging the glaucoma based on the amount of functional damage. As I said, it is used for grading the severity of the disease. So for that matter, an additional technological support with OCT or fundus camera and pachymetry will always have an additional advantage in structure function correlation and to form a reliable and acceptable baseline recordings to establish a proper diagnosis of glaucoma. So please note that for visual fields, always the best option would be to have standard or Humphreys automated perimetry, which is considered to be the gold standard. And however, There are other cheaper options available here to get a reliable and comparable to that of Humphrey's automated perimetry results, functional vision plotting, such as Melbourne Rapid Field, which provides really promising reports on the portable visual fields that are available in the market. So I say about Melbourne Rapid Field visual field test, because I personally have an experience on this. And however, there are other better and cheaper options as well, which I'm not aware of, which I don't have any practical experience on. So here, let's get into the skills and challenges. So now we'll slowly enter the skills required from our point of view as an optometrist, what are we need to have. And once we attain the skills, what are the major challenges that we have to face? So starting with the most important aspect of glaucoma detection, the skills required are history taking, which is always an important skill, and not only for glaucoma, for that matter, for any condition. It is only with careful listening and appropriate questions directed, you will get the information that helps you to get there. So listen carefully to what the patient says and direct your questions appropriately so that it can help you to form the basis of glaucoma. So clinical examination, which starting from general observation skills for various or important obvious signs, such as any associated syndromes and all, like Marfan's or Weil-Marchesani syndromes. So these are the obvious general observation signs through the minute details which we can pick up on the slit lamp examination, which involves a thorough knowledge on the utility of appropriate slit lamp examination techniques, including intraocular pressure recording by using a Goldman applanation tonometer or any other reliable equipment. And gonioscopy. In gonioscopy, I always go with the gold standard, which is considered to be the four mirror Sussman, and do not compromise on the gold standard technique for your own comfort, because it is difficult for you to handle the lens, or due to any reason, don't compromise on the technique. So try and learn to use for Sussman 4 mirror gonio lens for gonioscopy. Fundus examination using 90D 90 diopter lens, or 78 or any equivalent lens, or any, and grading the disc, preferably the disc damage likelihood scale, also called as DDLS scale. Please get yourself familiarized with that, and documentation of findings appropriately. Going on to the next slide, so this slide shows the continuum of the disease glaucoma. So this picture represents three stages, or various stages within that three different stages itself, starting from the undetectable stage through asymptomatic to functional, asymptomatic to a stage where it has a functional impairment. Though it is difficult to detect the disease in the undetectable stage, which is in the first stage on the left side, it is definitely possible to detect this condition in asymptomatic stage, which is possible only if your clinical skills are sharpened or trained up to that level. And that perfection in the skill is what one should aim for. And as I see most of the students who are attending this lecture, it is really an important point for you to start focusing or aiming at that kind of clinical skills, starting from this stage. Going on to the next slide. Yeah. So what are the challenges? First thing which comes to mind is the training, the quality of training, and the amount of experience required, or the amount of experience that one has got. So experience definitely matters, but what is important is to get trained in the right direction with appropriate skill sets required that will be enhancing your experience in itself. For example, having years of experience in not knowing what to look for is not worth as compared to knowing what dots to look for and how to connect them to achieve at a proper diagnosis of glaucoma. So here is a publication which says that if trained in optic disc assessment and gonioscopy, can appropriately diagnose glaucoma using these indicators. These indicators, in the sense, the optic disc and angle structures. So when clinical examination, clinical experience is added with an appropriate training on disc assessment and gonioscopy, this will help in glaucoma detection to an extent where diagnostic ability is as good as glaucoma specialist ophthalmologist. So here, one such publication which provides that a glaucoma specialist ophthalmologist can be replaced by a glaucoma trained optometrist to detect or diagnose glaucoma depending on the resources of a setting. So this comes with years of clinical experience and appropriate guidance and training. So a note to remember here. Yeah, so this is the publication where you can go into the details of this. And here, by saying your clinical skills, experience, and the diagnosis of glaucoma, while I say this, you need to remember that you are an optometrist and not a glaucoma specialist. So always aim for gaining expertise and providing a comprehensive eye care. So being able to detect glaucoma with high diagnostic accuracy should only be an additional skill from whatever other services that you can offer as an optometrist. So this should be kept in mind always, as long as you are in this profession. So what are the challenges in achieving those abilities? So individual motivation is an important factor, which this is the right stage for the most of the audience attending this lecture, being in student level. So this is the right age to develop that motivation, to improve that motivation levels, which plays an important factor to attain those skill sets, irrespective of the condition you aim for. I mean, not only for glaucoma, but anything. Polish your skill sets in such a way that the number of false positives for any disease are at the lowest. If you are practicing in a resource poor setting where you don't have a specialist, never mind to discuss with the available ophthalmologist in the nearby locality, or even an optometry colleague who you think that would help you to confirm your clinical observation or the diagnosis and involve in further management of the case. So this will not only improve your clinical skills, but also improves your network with professional colleagues, which can potentially pave path for mutual professional growth. This will also subside any professional rivalries that exists as well. So irrespective of the type of practice you are involved in, never restrict yourself to refraction or contact lens or any other specialization that you are into. Remember that you are an optometrist and you are capable enough to offer comprehensive eye care services. So I repeatedly say this just to make sure that you don't forget this point at any point of time. So moving on to the scope of optometrists. So what is the scope of all this training or the gaining this clinical experience? So here is one more interesting publication. I say interesting because it's mine. So there's obviously there could be a bias, but definitely this means a lot. So optometrists provide reasonable alternative for primary screening with no loss of detection ability. So this is proven clinically, and this method of effective training and gaining experience with appropriate collaboration will result not only in making you an alternative for glaucoma detection, but also will result in potential benefits to the community as a whole. So this expansion of this option, like optometrists being used as to detect glaucoma in the community. So option by increasing collaboration between ophthalmologists and optometrists can bring benefits in terms of lowering the impact of glaucoma on the community as a whole by increasing early detection and instigation of effective treatment to the patient. Right. So with this background, we'll just go into we'll quickly take you through some important aspects of glaucoma detection, like when starting from clinical, like patient history through the equipment or the skills required. So starting with patient history, so which will so in patient history, obviously there are many points given here, but I'll just quickly skim through that. So in a patient history, to start with relevant questions in ocular, medical and history related to risk factors, and to consider various associations for each of those questions asked, especially with the systemic conditions and also with the blood circulation issues to rule out blood circulation dynamics aspects of glaucoma. On slit lamp examination, never miss a potential risk factor such as narrow angles by Van Herrick's test and or the presence of pseudo exfoliative material on pupil borders or the anterior lens capsule or on the corneal endothelium itself. And also in pigment dispersion syndrome, signs on the corneal endothelium or changes in the iris, example, transillumination defects and extra, and angle structure changes on gonioscopy, and other potential signs which are potentially related to secondary glaucoma. Moving on to the disc assessment, the posterior segment. While assessing discs, always make it a point to comment on each of these parameters mentioned here, like the cup disc ratio, asymmetry between the two eyes, neuroretinal rim, the presence of Drans hemorrhage or hemorrhages, so course of blood vessels through the optic disc, whether they're just crossing across the optic disc margin, or do you see a notch or anything, or retinal nerve fiber layer health, and peripapillary atrophy. We'll go into the further details of this when we discuss some cases in the subsequent slides. And then assessment and equipment required for successful glaucoma detection includes intraocular pressure with applanation tonometry, eye care, or tonopen. So irrespective of the technique that you use, make sure that it should be reliable and repeatable. And these aspects of different tonometers were already discussed by Ramesh. Those who have attended his session would know. And CCT with pachymeter or anterior OCT wherever available, anterior chamber angle and with slit lamp examination and gonioscopy with 4-mirror Sussman, optic nerve head and retinal nerve fiber layer with slit lamp and fundus lens. So automated visual fields, which is preferable, but never a factor that precludes you from diagnosing glaucoma if you are sure about the glaucomatous structural damage, except in case of a preperimetric glaucoma. So the diagnostic equipment, which obviously differs from setting to setting. So diagnostic equipment usually includes the posterior segment, to like posterior segment OCT, to assess the ganglion cell complex or the retinal nerve fiber layer, anterior OCT or the angle structures, central corneal thickness sometime for pachymetry, and the anterior chamber, the angle structures. However, it depends on the geographic region and the economic status of the system because of the cost. So here we'll discuss now. I'll take you through some interesting scenarios which would help us understanding how your clinical skills and diagnostic equipment should complement each other. All right, ready for the yeah. So let me ask you all, what do you think the optic nerve head appearance of this patient would be? I'm pretty sure it should be normal. Even if you show me that report and ask me, I will say it is normal. So a message can be sent to the panel, or if you think it is otherwise. So next slide. Here we go. So is this a normal disc? How many of you think this is a normal disc? If yes, they can discuss with me later. If no, obviously, for me, it is definitely not a normal disc because yes, I see a couple of responses. So what all to look for? I'm not going to comment on what it is, but I'll just go take you through what all to look for. So the disc size, starting with the disc size, which appeared to be big, because there is no comparison. I cannot say definitely, but it appeared to be big. And however, that is a subjective comment. A cup disc ratio, which for me it appeared to be about 8.5:1. And blood vessels, look at the course of the blood vessels, especially inferiorly. They're just tracing out from the margin. Okay. And retinal nerve fiber layer, obviously retinal, this is not a good picture to comment about retinal nerve fiber layer, but still there is a definite absence of neuroretinal rim in the inferior sector of the disc. So this ideally should come up with a correlating visual field defect in the superior arcuate region, but that's not what we see here. This is the fields of the same patient, which shows practically normal field. So now let's look into the advantages of having technologically advanced imaging equipment. Now we have an OCT, which definitely shows a good, beautiful retinal nerve fiber layer defect inferiorly in the RNFL thickness map, which where you can see that there is no color pattern maintained in the thickness map. And if you see the retinal nerve fiber layer RNFL quadrants, each of those 4 quadrants, inferior and the temporal quadrants are completely thinned out. And the same thing is seen in the clockover-wise thickness as well. There's a significant thinning in the clockover-wise thickness and also in the RNFL deviation map. So in this situation, what I would like to say is your clinical skills should only complement with the available technology. Okay, so it shouldn't be like your clinical skills should not be completely dependent on the OCT. Once you see OCT, definitely, don't just go with whatever OCT says, because sometimes OCT or the fields might give you an unreliable result as well. So ultimately, both of these, your clinical skills and the other information should work hand in hand, should be complement to each other. Now we'll consider another scenario where we have a beautiful OCT report. So in this, as we can see this OCT report, and this is This is also not from my list of patients, and this is taken from the literature, and it is cited as below. So the OCT, which shows normal values all over, and when I say normal values all over, you can see all green, all the quadrant-wise 4 quadrants and the clockwork quadrants, also the GCC, and also the final result of the entire OCT showing within normal limits in both eyes. So when your clinical skills, when you're not really good at clinical skills and dependent only on OCT, looking at this, you can just say that you can send off your patient by saying that it's all normal. But let's see what clinical examination looks like. So how many of you all think that this correlates or this goes well with that OCT report? Okay, so I'm sure most of you don't agree with that. So clinical examination or a red-free fundus photograph, which you can see on the screen, of the same patient left eye showing an inferior retinal nerve fiber layer damage. So you see a dark wedge-shaped defect starting from the disc, going in the inferior arcuate region, a shadow kind of a thing. So that's inferior retinal nerve fiber layer bundle, which you can see as a wedge-shaped defect, wedge-shaped shadow. So the bottom line is that irrespective of all the fancy toys or the imaging equipment that you have, your experience or the clinical observation skills and your thought process that goes into the decision making of saying that this patient has glaucoma is all that matters. And never rely only on the computer generated reports, or when in doubt, never rely only on your clinical skills. When in doubt, take a second opinion. Make sure that these equipments are used as something which helps you to 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 provide a second opinion or further detailed understanding of the structure function relation. Going on to the next slide. Yeah. So with all this clinical experience and whatever I spoke about the way you need to the clinical experience and the availability of resources, where is this going to? So, or the collaboration between professional colleagues. So this will ensure that glaucoma detection becomes an integral part of the eye health delivery pyramidal model at the base of the pyramid. So you need to, I'm sorry, I couldn't provide an image of the eye health delivery pyramidal model, but I expect most of you are aware of the pyramidal model. So with all these points that I have covered till now, it will make sure that, once the optometrist is good at his skills, we can assume that we can definitely take it for granted that the glaucoma detection can be started from the base of the pyramid itself. And this holds true not only for a resource poor setting, but also I'm sorry, in technologically advanced communities, because of the ratio of the number of glaucoma specialist ophthalmologists or ophthalmologists, specialist versus normal or comprehensive ophthalmologists. I'm sorry, just need to sit down. Sorry about it. So the number of glaucoma specialists available versus the number of people actually suffering with glaucoma, and also the percentage of the number of people actually affected with glaucoma. And the people, we should also consider people who are still undiagnosed or unaware of the condition, which needs to be kept in mind. So this will help the ophthalmologist to focus on the medical or the surgical management of those with glaucoma. So this is again from the same publication which we have discussed in previous slides. So for any given scenario where it is difficult to match the percentage of the specialists versus the prevalence of the condition, optometrists are an absolutely viable option in detecting and playing an important role in the management of the condition for the benefit of communities. And this is the first publication on the prevalence of glaucoma as reported by an optometrist, and in a setting where providing a glaucoma specialist ophthalmologist or an ophthalmologist is not practically possible. And to be practical, having an ophthalmologist to diagnose or detect glaucoma in a primary eye care setting is never a viable option, irrespective of the geographic region, which I'm sure everybody is in a position to imagine. So, this model uses the existing eye health delivery model clubbed with a glaucoma trained optometrist to inculcate glaucoma detection both horizontally and vertically from the base of the pyramidal model, the eye health delivery pyramidal model. So, this design has worked in India, which I have personally seen and reported. So, I have also witnessed personally that this model has a potential to be a successful one in regions like Bangladesh and in a continent like Africa. So you can go through that model. Now, going to the current model, which is the Specsavers model. So, because as you all know that I'm an optometrist working in Specsavers, New Zealand, and soon will be shifting to Australia as well. So I'll be discussing the Specsavers model and the kind of impact that we have created in the community. So, so when I say Specsavers model, this essentially means that the availability of technologically sophisticated equipment required for glaucoma detection, not only glaucoma for that matter, but posterior segment conditions, and along with structure function correlation. So in this model, a spectral domain OCT scan is done on all the patients who come for an eye examination. So this is indeed a revolution in the field of eye care and has proven to improve the lead time in glaucoma detection by up to 8 years on visual fields alone. So because of the presence of OCT scans on every patient who attend for eye examination, the false positive rate of glaucoma referrals to ophthalmologists was decreased to about 17% from over 20%. And this obviously had a significant impact on the professional time for both optometrists as well as the ophthalmologists. So this model has also reduced the level of undiagnosed glaucoma among patients, among this patient pool, Australia, New Zealand patient pool, by about 60% from this region. And this also suggests that in this population, about 75% of the open angle glaucoma cases are uncomplicated and can be managed by the optometrist. So for that, obviously, optometrists need to be therapeutically endorsed for prescribing glaucoma medications. So moving on to the take-home message. So always aim at improving your clinical skills either by additional training or by getting yourself therapeutically endorsed if necessary, either for glaucoma or for overall your professional growth. And always aim to provide comprehensive eye care. And remember, glaucoma detection is only a part of your opportunistic screening. And you are there to provide a comprehensive care. In that, glaucoma is only a part. Encourage shared eye care practice whenever and wherever applicable. So the only way you as an optometrist can influence any healthcare setting is with your excellence in quality of the work that you do, which means that aim for excellence in patient care and your towards your profession. So the last but not the least is that you are so privileged to be in this profession, that profession of optometry. So always aim to reach the most underserved populations of any community that you're working with. Don't just sit in the cities, but there are uh, there are many regional areas where people are waiting to be seen by you. So aim to provide your services to those populations as well. So here are the references that I have used for this session. And with this, I would like to congratulate the OOLS team, and especially Fakhruddin, and for this for starting this amazing platform, which is really impressive, and all the hard work that is going through is really amazing. Congratulations, team. And at the same time, I would like to wish all the students good luck for your career, and thanks for attending this session, and I'm open for any questions now.
So thank you, Dr. Uday, for that. It was more of kind of a motivating thing, which is really important, right? And I think it was an apt time because we had majority of students, and the way it is important for the students who are going to enter this field. It's really important for them to know that this is I would say it's an untapped section of optometry which people don't really look into very seriously, right? Okay, great. Okay. So this is one of a clinical based question. I think you did mention about the drains hemorrhages. Any difference between the drains?
It's the same.
It's the same. Okay. It's just a different.
Yeah.
Yeah. Right. Okay. Let's look at the second question. Is there any particular referral scheme which we can follow? I know you talked about the pyramid, but any referral scheme?
So here I was particularly very careful in talking about the referral pattern, because it changes from various jurisdictions. So each region has got their own referral patterns depending on the role of optometrists, or the regularization of the profession of optometry. So so all these things can be, whether it is there or no, whether set rules are there or no, irrespective of that, with your clinical skills, once the ophthalmologist is convinced with your clinical skills, when you say that this patient has glaucoma and he needs an immediate care by you, obviously they would not say no.
Yeah.
And they would be happy to accept a patient referred by you, and there would be a positive relation that can grow between the two practices. So it doesn't require no referral pattern or a scheme should stop you from suspecting a case to be having glaucoma and referring.
Okay, great. And let's moving on to another question. Can you explain how to diagnose or look out for symptoms of normal tension glaucoma and primary open angle glaucoma? Any quick tips as per your experience goes?
Well, when you wanted to diagnose a case as normal tension glaucoma, first of all, confirm that the pressures are normal by doing a diurnal variation test, and also ruling out all the other systemic conditions, or the blood dynamics of the patient are ruled out. As we all know, and we had been learned that the normal tension glaucoma is a diagnosis of exclusion. So exclude all the other possibilities, and when you are still left with normal pressures, CCT correlated normal pressures, and disc damage, glaucomatous disc damage, correlating visual fields, then you should consider that patient as normal tension glaucoma and start treating. And the question also has primary open angle glaucoma. Normal tension glaucoma is a type of open angle glaucoma itself.
Yes.
Once you rule out by doing this diurnal variation test and you rule out normal tension versus the highest peak, if it is more than 23 or 24 millimeters of mercury, then that goes to an open angle, primary open angle glaucoma. If the pressure spike is less than 23 then or 24, then it is normal tension glaucoma.
All right, great. Okay, and moving to the next question. Yeah, it's again about the follow-ups and referral system. Will the optometrist have any trouble if the patient gets into any problem during follow-ups? I think it's more related to ethical as well as the legislative part. And does optometrist need to take any liability?
Did I talk anything about you treating as an optometrist? No.
No.
So all I said is to polish your skills or train yourself to a level where you are in a position that you are not missing any subtle finding related to glaucoma.
Yes.
So when you see a definite glaucomatous change, when you can explain that to the patient with images and refer that patient to the ophthalmologist, and obviously when you are confident on the findings, obviously ophthalmologist also will go with that, and obviously ophthalmologist will not refuse to start treatment.
Yeah.
So the patient would come back either for follow-ups if you develop that system with the ophthalmologist, that you will look after the every 3 monthly intraocular pressure checkups, or the ophthalmologist can take from there onwards.
That's right. And I think what is more important, I think your talk was more on how can we not miss glaucoma, right?
Yes.
That's how detect. That's the most important part. And I think that's the start. Once we know how
Yes,
to detect,
exactly.
it's a building block. So if we are building the whole building, right?
Yes. It all starts with that one step.
Yes. That's right. And I think I can relate this very well with the thoughts, because when I was into clinical practice back home in India, I'm talking about 6 to 8 years back, when I was working with the ophthalmologist, and we were in the same premises, but then he would only see a glaucoma patient after 6 months or 8 months. But I would be seeing the patient probably every 2 months, because the patient would come in. I would do the intraocular pressures, if required, do a gonioscopy or OCT. And if I think he needs to see the ophthalmologist, the patient would wait. If not, I'm the one deciding when is the next follow-up. So your role as the
Yes.
ophthalmologist is really important.
Yeah. So even in my personal experience, once proved in your in your standard of care, the excellent standard of care, I was always throughout my career, I was always privileged to be working with ophthalmologists who had given me that freedom to look after those glaucoma follow-ups and all those patients and all the tests required for glaucoma.
That's right.
So it is only because of the confidence that they have developed after seeing my clinical skills. So it is that which plays an important role, so that winning the confidence of your team member.
Yeah. So developing your own skills and making sure that you are pinpointing that slightest or the smallest change which you have to, and that would be very important.
Yeah.
Okay, great. And one last question, Dr. Uday, is just coming up here. Is what do you think are the role of these? I know you did mention clinical test is really important. Look at the fundus, do a 90D, do a 70AD. But nowadays, these are new instruments coming up whereby you can do a lot of imaging and all those things. So what do you think is the role of these newer instruments versus the clinical set of skills we need to have?
Yeah. So in my experience, I have worked in a setting where I just had access to a 90D and slit lamp. So that had never stopped me from providing glaucoma care or to detect my glaucoma patients and referring. So I was never dependent, neither my, I can proudly say that all those optometrists trained by me are never dependent on these fancy toys.
That's right.
Okay. So as I told, it is only a complementary to your clinical skills. When in doubt, when you really need, suppose that I give you another scenario. A known patient of glaucoma for last 10 years and on glaucoma medications and just using medications as advised 10 years ago and never followed up, and comes back with advanced disc damage and 10 years old fields reports. So in that stage, I was in a setting where I don't have an access to automated perimetry. So in that stage, the only possibility I had was to do the MRF, the Melbourne Rapid Field Test, which definitely I can strongly say, and even the literature says that it is quite comparable with automated perimetry, and that had given me similar report, similar result as that of what it was 10 years ago. Okay, so except in that case, I never had to rely on any further these fancy imaging techniques.
That's right. Yeah.
Yeah. And for this, I had to think about the Moorfield, sorry, not Moorfield. I always go with HRT Moorfield. So
Yeah.
this is Melbourne Rapid Field. I had to think about MRF because it also depends on the person who is doing this test. The quality, if it is OCT, the signal strength or the scan quality. If it is the visual fields, the perimetrist or the technician who is doing the test. Because when I referred to a tertiary center for this patient to get the visual fields done, this patient came back with advanced complete loss, VFI almost zero. So because I was expecting that patient should have tunnel vision, at least the whatever fields which she had earlier, at least that should be remaining. So I was expecting that, but this patient has come up with complete advanced field loss. So in this case, I could not rely on some other perimetrist whom I did not see the way I don't know what they have explained to the patient. So the only way I can do is I could think of MRF, and I did it myself in the clinic along with my colleague optometrist, and we found that the result is same as what it was 10 years ago. So I don't think you really need to depend on any kind of equipment. If you have, it's well and good. If you don't have, you should focus on your clinical skills.
That's right. And these fancy equipments, I think, should not be something which is stopping you from doing the examination.
Absolutely. Yes.
Okay. So, what would be better, doing fundus examination or doing IOP, or which test do you think should be done at all follow-up visits? Probably, if I can modify the question that way.
Let me look at the question completely because this window is blocking.
Sure.
Taking a fundus examination be a better basis for diagnosis than checking the. So if you have asked about the same question, then I think I have mentioned this point in my at some point during my session, where the maximum number of information that you get, the better it is.
Better, yeah.
So never be lazy to get an additional point. So when a patient has come for follow-up, don't be lazy to stop your examination after IOP. Look at the optic disc as well. Optic disc, retinal nerve fiber layer, slit lamp examination. Start with vision, slit lamp examination, Of course, it should start with history, every visit, history, whether the patient is on medication. If yes, what are the medications? When was the last application or last instilled with timings?
That's great.
Should start from that. And last gonio, because every 1 year you need to repeat gonioscopy to see how angle structures are, and to see to do the visual acuity, and then slit lamp examination, a careful slit lamp examination again, and IOP, and then fundus examination. So all these things have to be documented at every visit.
At every, so it's for the diagnosis and also for the follow-up, where you
For
must
follow-ups.
for the
Yeah.
follow-up.
And every 1 year visual fields, 1 year to 6 months as required.
Great. Okay. And does your plan change in terms of evaluation when there is a family history of glaucoma? Again, this just popped in, so I thought let's just talk about this. When you have a patient who has a strong family history of glaucoma, what will be your follow-up process? Will you be still doing that, or how would you go about these patients?
Family, if this is the question for that, family, strong family history of glaucoma, like say both the parents have angle closure glaucoma, and this is a 40 to 45-year-old patient, and he has got a refractive error which is hyperopia, and that correlating with shallow anterior chamber, immediately do a gonioscopy and rule out primary angle closure disease. So when I say primary angle closure disease, because it is a spectrum of primary angle closure suspect, primary angle closure, primary angle closure glaucoma. So all these three together is called primary angle closure disease. So rule out if this patient has got any of these occludable angles. If yes, then immediately refer for laser. If laser is done, post-laser management is all done and pressures are normal, then just do a repeat one every yearly gonioscopy and follow up.
Okay. So
if everything is normal, then just follow up every yearly.
Yeah. Okay, great. And yeah, I think people are now getting more.
That's okay. I'm ready to take.
Yeah, let's just take one. This is again, I feel, is a bit important, I guess, in terms of therapeutic rights. You know, if let's say we have the therapeutic rights and we are able to prescribe glaucoma medications. I do understand we are only talking about detection, but let's just take this one as well. What is the first drop of approach? As the guideline says, the first drop of approach is the treatment. So any thoughts on that? What would you want to advise optometrists on this particular thing?
As I said, it depends on the irrespective of the region. It depends on the jurisdiction. So if you are in some regions, even though you are therapeutically endorsed, you need to be qualified to prescribe or to manage for these glaucoma patients. So depending on that, you need to see whether you can manage or you need to refer to an ophthalmologist.
That's right.
Irrespective of anything, wherever you are, whether you're in an ophthalmologist practice or anything, you need to start with immediate. The first line of management would be medical management, and then the combination of medications. If nothing works, then go to the surgical management. In some regions, it is also like medical management is also clubbed with selective laser trabeculoplasty, which is a laser procedure, but an outpatient procedure, which is a simple and day procedure.
Okay.
So it depends on the region, obviously.
Depends on, and also I think a lot of factors, right? It depends on the when you see the patient and then the condition,
So
the state.
whatever it is, whatever is the region of practice, it has to start with medical management first. And if medical management is not of any help, then you need to think of surgical management.
That's right. Yeah. And I think our role as optometrists would be counseling the patient. So we have to let patients know, right, that this is the management options. So I think the reason why I wanted to talk about this question is we probably, not all of us would be under therapeutics, but we
Yes,
are
that's
confident, right? So we have to tell our patients that, it's
and
medical first.
yeah, and another important point which I wanted to add, now that we had this session and a reasonably good discussion about all these things, from tomorrow onwards, don't look at a large disc or a suspicious disc and don't say the patient that, oh my God, you have glaucoma.
Yes.
Don't say that. Okay, this has a major psychological impact on the patient, because remember that glaucoma is a blinding disease.
Yes.
That patient might be a 40-year-old with a young family who might have started his family very recently. He might be having many dreams. So don't put a psychological burden on that particular person. So
That's
just try to learn how to convince, how to explain. Even the intraocular pressure is 50, even the patient has an advanced optic nerve damage. Take time to make sure you explain to the patient appropriately and give the patient that strength. Don't just say that, oh my God, you will go blind in the next few months.
yeah.
Okay, that is very, very dangerous. Please don't do that.
That's right. Yeah, and I think when they Google glaucoma, the first word or phrase comes out that it's a sight-threatening disease, and it's a disease which will eventually lead you to blindness. So your patients will Google, but then when you are counseling, you have to make sure that you comfort them, as Dr. Uday was mentioning. Great. Okay. So I think with that, thank you so much, Dr. Uday, for that session. I think really important, a good discussion, very important point discussed. And thank you so much for giving us the time.
Thank you so much, Fakhruddin, and wish you all the best to you and the team. A fantastic job. I was like the other day, I was discussing with Bruce as well.
Yeah.
So Dr. Bruce Moore as well. So we were appreciating all your efforts. Fantastic. Keep it up.
Most welcome. A quick announcement that from next month, which is May onwards, we are shifting to one session a week. So instead of a Saturday and a Sunday session, we will have one session over the weekend, either a Saturday or a Sunday. So take care, everyone. Thank you so much for joining in today. Be safe, and I hope to see you next week. Bye bye. Okay.
Well, thank you all.
Thank you.
Thanks
Have a
for
good, I think it's almost late evening for you. Have a late evening. Good evening.
that's okay. Yeah, that's great.
Okay. Bye
I
bye.
enjoyed this session as well.
Thank you so much. Yeah, me too. Yeah.